So what is the difference between opiates and opioids? A lot of people ask. And traditionally, we used to refer to opiates as more kind of naturally occurring opiates that come from the poppy plant. So things like morphine, things like codeine, heroin, and opioids were more synthetic. So when we're talking about the difference, we're talking about coming straight from the plant versus coming from a clandestine lab or from a pharmaceutical source. And I know that they make methamphetamine and not opiates on Breaking Bad, but I just thought it was a kind of nice visual. So in terms of the opiates, whether it's opiates or opioids, they both work on the opiate receptors. We also have what's called endogenous opioids, which are peptides or proteins that are within our body that also work on the receptors. And what these chemicals do is they are best known for causing pain relief. They do cause a sense of euphoria in certain people, so a sense of calm, a sense of happiness, which is where some of the abuse comes from. But it can also slow down breathing, and that's part of the concern in terms of overdose. If we look at therapeutic uses of opioids, analgesia, like we said, is kind of the most common. We know that they're used for pain relief. They are also used for anesthesia, so in certain surgical procedures to put people to sleep. Cough suppression is an interesting one. We know that we have over-the-counter cough syrups that are available and prescription cough syrups that have things like codeine in it, even dextromethorphan, which is a great cough suppressant, and doesn't really have a ton of pain-relieving activities, but still can be used for hallucinogenic properties, so it still is abused, even though it doesn't really cause a lot of pain relief. It's called skittling or robotripping, and a lot of youth are actually using this in kind of inappropriate ways. Antidiarrheal. We know that people who take pain medications with opiates do very often get constipated, and we can use that with things like Imodium or loperamide, which is great if anybody's suffering from very hyperactive bowel. The problem is, because there is opiate activity in it, there are some people who've kind of discovered if you take massive amounts of Imodium, you can actually get a little bit of a high. And so people go to Costco and buy the extra large container of Imodium, and we have had people get into trouble in terms of taking excessive amounts because there are potential cardiac risks from it. And so even though it's over the counter and seemingly safe, can be abused. We also use opiates, as we'll talk about with certain opiate agonist treatments, to detoxify from other opiates. And when we look at side effects, or what opiates cause, the one that we're kind of most concerned about today is the central nervous system effect. So how does it affect your brain? Does it affect impairment? Does it cause fuzziness? We know that people do often get happy when they use opiates, so some people will describe feeling kind of a warm, fuzzy feeling when they take it, as opposed to just having pain relief. Some people do get dizzy, they get lightheaded, but because these opiate receptors are in other parts of our body as well, not just our brain, we do get other symptoms like nausea, like vomiting, like constipation. Opiates can cause urinary retention as well, so people can have difficulty in terms of going to the bathroom. Respiratory depression we talked about, which is one of the risks of opiates, so it can turn down the signal for people to breathe. And again, that's where people run into problems in terms of overdose. So when we use opiates, we get release of chemicals in the body. The problem is after we use the opiates and those chemicals are dissipated, people can feel what we call after effects. So they can get depression, they can get anxiety, because again, when you take the medication, it can make you feel happy. Once you don't have it, you get that kind of decrease in terms of that chemical high, and so you can feel quite depressed and quite anxious. When people don't have opiates around, they get significant cravings, and these cravings in themselves can be impairing in terms of their ability to work because they're constantly thinking about where they're going to get kind of the next dose. A lot of people use opiates to energize, and so when they don't have them, they can feel fatigued. And tolerance is another important thing. So once you've been taking opiates for a while, you can develop tolerance, which means that the opiates that you're taking don't work as well, and you're not getting the same effect, and you need to take more and more and more just to be able to get that effect. You can also have withdrawals, which we'll talk about, which can also interfere with your ability to work and can also be impairing even when the drug isn't around. And then opiate-induced hyperalgesia is a fancy way of saying people who've taken opiates for a prolonged period of time can actually sometimes be sensitized to pain. And so they can actually feel pain more than before they were taking opiates, and they can actually get quite sensitized to it. So your brain is not really responding to the opiates that are around as well, and so you're not only not getting the pain relief, but you're actually feeling increased pain. I was at a conference where there was a psychiatrist talking about de-prescribing. So there's all this excitement right now about physicians prescribing opiates, and what he was focusing on is actually trying to reduce the amount of opiates that people were on to actually improve their pain control. And he was actually seeing that people who were taking less were actually having improved function and having decreased pain. The other thing that a lot of people don't know is that opiates can decrease sex hormone levels. So if you're trying to engage a patient to try to lower the amount of opiates, that's a really important selling point, because nobody wants their testosterone levels to be low. Got to get buy-in wherever you can. So in terms of excess opiates, what we worry about and things that you're concerned about in terms of impairment, a lot of opiates cause what we call clouding. So people just feel like they're in a bit of a fog. Cognitively, they just don't feel like they're all there. They don't feel like things are clear. If you take excess opiates, your speech can get slurred, which is a nice, easy identifier. Some of the other signs of opioid toxicity, not as easy to identify. People do definitely say that it affects their ability to think clearly, their ability for decision making. And when we get into kind of employment issues, we'll talk about how these are concerning in terms of someone working in a safety-sensitive environment. People who take excess opiates, especially some of the addiction patients that I see in my clinic, it's very obvious when they've had too much, because they do this very characteristic nod where they're falling asleep and their head is kind of bobbing up and down in the waiting room. Once they get to the point of respiratory depression, we're kind of in a bit of trouble, and decreased heart rate as well. And when people present to the emergency department, we have this kind of triad of suspected opiate overdose, where if they're coming in with, it's a little bit hard to see, but if they have decreased level of consciousness, if they're pinpoint pupils, so your pupils get very tightly constricted, and if they're in respiratory depression, the first thing that people think about is, could this be a potential opiate overdose? And then what they do is they administer an anti-opiate, such as Narcan, to kind of see if you can get the person back and improve their consciousness. So these are all the symptoms that you have when you're using opiates. What happens if you've been using opiates for a while, and then all of a sudden you stop? So the withdrawal from opiates is quite unlike withdrawal from most other illicit substances, in that, yes, there is a psychological component, but there is a very, very strong physical component to the withdrawal. And depending on the opiate they were using will depend on the timing of the withdrawal. So initially, the first couple of days, people can feel really tired. Their sleep patterns are very, very disrupted. They can't fall asleep. They're waking up every hour. Myalgias or muscle aches are very, very common, so people just feel kind of like they have the flu and everything just hurts. They get profuse sweating, hot flushes, and then that just kind of progresses from there. So I think I said this last year, when you have opiate withdrawal, when you think about anything in your body that can leak, leaks, which is not a lovely picture. And we were talking, I think, about vomiting earlier today. But really, people get vomiting, they get diarrhea, they're pouring sweat. Maybe opiate overdose over there. They're pouring sweat, runny nose, watery eyes, everything is just pouring. And it's like having the worst flu of your life times 1,000. So, when we tell people who are taking opiates, well, you can just stop them, it's not really very realistic to tell someone who's been on opiates for a prolonged period of time to just stop, because they do feel kind of like they want to die. And the important thing is this can still interfere with their ability to work. So even though they may have a negative drug test and they may not have opiates in their system, if they've been taking it for a prolonged period of time and then all of a sudden they know they have to stop, they may not be functional. And this withdrawal syndrome can last for weeks and months. So the insomnia is prolonged, depression, just feeling irritable, having lethargy, feeling no energy at all. And so it's an important kind of aspect to consider in someone who's been on a pain medication for a prolonged period of time. So why is there so much to say about opiates? Why is it such a complex issue? I mean, it's a prescription medication, you take it, should be the end of the story. Except that if you look at some of the words that you see there, I mean, you have pain relief on one hand, which is great, and I think there was, death or overdose on one side as well. I mean, really, opiates can be great. It can be life-saving for certain people. It can improve their function. It can improve their quality of life. But then on the other hand, we have all of these other potential risks in terms of opiate use and all of these other potential implications. So someone who's started to abuse opiates can have legal implications in terms of how they're getting it or the activities they may be involved in to be able to afford to buy their medication illicitly or their drugs illicitly. Health implications. So are they impaired and going, getting behind the wheel of a car? That's certainly a risk. Are they starting to inject drugs and potentially exposing themselves to health risks in terms of using, infected needles? So there's huge social, legal, economic, employment consequences because of use. And if we look at what opiates are being used today, so Tex, Percocet, oxycodone and acetaminophen, they were readily prescribed for long periods of time. People can start taking them. They generally take them orally. If they're going to abuse them, very often will snort them, which causes a whole host of side effects in and of itself, because then they get kind of addicted even just to the behavior of snorting something, even if the medication is no longer providing that euphoria. Morphine sulfate is a prolonged morphine preparation. Dilaudid is hydromorphone, so shorter acting medication, but being used a lot now, and we'll talk about why. Hydromorphcontin is basically a long-acting version of hydromorphone and was kind of designed so that you only need to take it twice a day instead of kind of getting pain relief for a few hours, having pain again, needing to take something again, so trying to avoid the ups and downs. It's thought to be less abusable because it's got little gel beads inside of it that if you mix with water will gel together, making it harder to inject. Although if there is a will, there is a way. And there are cookbooks online that will tell you exactly how to prepare the hydromorphcontin so that you are able to inject it. Fentanyl patches. So fentanyl, I think we've all been hearing about in the news. Fentanyl patches are prescription medications that were originally designed for cancer patients, which, if worn, release a steady amount of fentanyl in the bloodstream over a period of 2 or 3 days, and the patches are changed. The problem is people who want to abuse the patches will disrupt the matrix of the patch, cut them into strips, smoke them or chew them, and when they do that, you don't get a nice regular amount of fentanyl being released into your bloodstream. You may get a strip that has no fentanyl in it. You may get a strip that has way more fentanyl in it than what you're used to getting, and so quite dangerous, especially if not used properly. And then if we're talking about illicit substances, heroin, either white or brown. And a lot of the heroin that's out there now is this purple stuff, which is actually powdered fentanyl. The theory is the purple is mixed with Kool-Aid so that dealers can try to put their own kind of label on whatever batch they have. And some people are requesting the purple stuff. Some people want to make sure that they're avoiding the purple stuff because they know how potent it is. And we'll talk a little bit about the differences between fentanyl and heroin. If we're looking at street names for opiates, codeine we have over-the-counter in Canada, which some people have discovered and are quite happy about, but people run into problems in terms of abusing the over-the-counter codeine because of the amount of Tylenol that's in it. And so they're taking 20, 30, 40, 50 tablets a day, and the amount of codeine may not even be the biggest issue. It may be the amount of acetaminophen that they're getting in, which is toxic to their liver. But really, there's street value to pretty much every opiate that's out there. And if we look at how you're going to get your opiates, there's different ways of getting them. So there's legal ways, over the counter, which we said in Canada, not in the US. So codeine is Schedule I, not available over the counter in the US. Or you can get prescription medications. Illicitly, you can buy things off the street. You can order things on the dark web, and we'll talk about how that gets delivered and how easy that actually is. You can be using prescription medication in an unauthorized way. So either prescriptions that were given to you that you're using not really under the guidance of a physician, so either not under the correct time that they're telling you, maybe you're not taking them in the correct amount, or maybe you're using someone else's prescription medication, which happens a lot. You know, how many people have a bottle of Tylenol 3 left in their medicine cabinet from when they had their wisdom teeth pulled? It happens quite a bit more than you would expect. So when we're talking about prescriptions versus illicit, if it's legal, people assume, well, I have a prescription for it, so I'm okay, because it should be fine. And as an MRO, when we talk to them, if they have a medical authorization, then you may have a negative test, but does a negative test mean that you're safe? And we know from looking at studies that people who are on prescription opiates, so these are people who are taking their medications the way that they're supposed to be taking them, prescribed under a physician's authorization, are still at significantly higher risk of motor vehicle accidents. This risk increases substantially more when there's other substances involved. So someone who may be drinking, taking benzodiazepines or sleeping pills with it, and if you look at the concurrent risk, 21 times the risk in terms of a fatal crash involvement. And if you look at 72%, this is not a small risk that we're talking about. And again, these are people who are taking medication the way they're supposed to be taking them. So the important take-home point is, just because there is a valid prescription does not mean there is no impairment. And that's why when we do the MRO reviews, if somebody does have a valid prescription, we let you know if there's any safety concerns. So if this is someone who's on a chronic opiate, whether it's low dose, whether we think that they're taking it appropriately, we will let you know so that you're aware of what to look for. The Canadian Centre on Substance Abuse was talking about the risks in terms of driving impairment. So naive users, so people who aren't used to taking opiates who are on them, but even experienced users who may be combining them with other intoxicating substances or impairing substances, or users who are using them maybe in excess of what they're supposed to be doing. And again, take-home message is just because there's a prescription there, it doesn't mean that it's safe. So, red flags as an employer. Lots of different ways to kind of identify if you think someone's either taking medication or running into a problem in terms of their opiate use. So they maybe not doing their job the way they're supposed to be doing. So Paul talked a little bit this morning about presenteeism. So showing up to work, but something's just not right. They're not able to get their duties done at work. They're missing work. They're just kind of not interested. People who wear long sleeves when it's 30 degrees outside, you got to be worried. Are there track marks maybe that they're trying to hide? If their pupils are pinpoint, that may be a sign that they're on opiates. They're just not really their personal hygiene. Their weight has changed. If you're seeing someone when they're euphoric, so right in the middle of the acute effects of the opiates, or someone who may be nodding off, all of these are signs that maybe somebody is doing something. Or if you see someone who's in withdrawal, if you see someone who's having hot flushes all the time, or who have goosebumps, or who, constant runny nose, that also can be a bit of a sign. Employment concerns. So, we worry about, has someone been hurt at work and is starting to take opiates? Because it's going to take them longer to get back to work. It's going to cost you more money in terms of productivity. Are they starting to, use because of the workplace injury, or do they have a workplace injury because they were using opiates and something happened because of the impairment? Did they start to get on a prescription because of an injury and now they have an opiate use disorder, which we'll talk about? Are you having to deal with someone who's nodding out at work and potentially having to deal with an overdose? And if you're having to deal with an overdose, when we're going to talk about certain opiates that are actually potentially risky for first responders who are trying to help people who are in overdose. If we look at the statement put on by the American College of Occupational and Environmental Medicine, they did say that acute and chronic opiate use in various different safety-sensitive positions, and there's a whole list there, especially ones that involve high levels of cognitive function and judgment, it's not a good idea. And now, I'm going to talk about the opiate crisis. And I know there's an opiate crisis, number one, from reading the paper, number two, from talking to my patients, but number three, I go to the Canadian National Exhibition in Toronto every year for the last 20 years with my kids, which is aging me a little bit, but, and for the first time this year, you know, there's food and games and lots of cool things that you can buy from and they had a naloxone booth. And they were doing naloxone training at the exhibition. There was a pharmacy that had set up, they would do naloxone training. You don't need a prescription for it, and this is basically for opiate overdose. And they were handing out kits, and it really struck home with me as to how widespread this problem is. And so I thought we'd talk a little bit about, you know, how did we get here? Because people have been using opiates for thousands of years. People were smoking opium and drinking opium tea. They used it for socialization. They used it for medical purposes. But how did it come to crisis situation? So this young pharmacist, Frederick Sir Turner, was able to isolate an active ingredient from opium. And as young people do, he made maybe not the best decision to test it out on his buddies. And he didn't really understand in terms of potency and dosing, so he ended up giving his buddies like 10 times the normal dose of morphine. And clearly they had a lovely time with it because they ended up naming it morphium after the god of dreams. And basically, morphine was used for many different medical purposes. So I found this reference for a soothing syrup that was on the market. Had 65 milligrams of morphine plus alcohol in case that wasn't enough for you. And this was sold legally it was developed by a pediatric nurse. Her name was Miss Winslow. And this is how it was marketed. A mother's kiss. It is absolutely harmless, no concerns at all, except that a teaspoon of it had enough morphine to kill a child. And the soothing syrup had a different nickname. It was actually called Baby Killer, which is, there were many infants that actually perished because of use of this medication, which was totally safe and completely harmless. It took a long time to get it off the market. So the AMA kind of denounced it, but it wasn't until like the early 1900s, 1930s, that it was taken off the market. So another medication that Bayer manufactured in the 1890s, I think you've heard of it, heroin, was great as a cough suppressant, great for pain relief. Again, if you look at the last line, it's marketed as non-addictive alternative to morphine. Well, we all know how that turned out, because heroin is not addictive. It's in fact quite the opposite. It has an addiction rate of about 25%, which means out of 4 people who try heroin, 1 of them is going to be addicted to it. Fortunately, Bayer stopped making the medication. It is now not legal. But this story of marketing something and then heavily marketing it as being safe and not addictive, we've heard that recently in terms of other medications, right, that were very heavily marketed. So if we look at the history in terms of OxyContin, if we actually go back before the days of OxyContin, in the 1980s, there was kind of a phenomenon that was called opiophobia. So doctors were a little bit leery about prescribing opiates, and people thought they were under-treating pain. And then there was a letter in the New England Journal of Medicine. So this was not a study, this was not research that was done, it was just a letter in the New England Journal of Medicine that basically said that addiction is rare in people who are treated for pain relief with narcotic medication. This letter was cited multiple times by many physicians, and this is thought to have propagated part of the opiate issue because they kept citing this letter. Well, this letter referred to 2 people who had looked at some research. They looked at about 40,000 patients that had been in hospital. So these are not people who are on chronic opiate therapy. These are out of 40,000 patients that were in hospital, About 12,000 of them had been given opiates, and they said, well, only 4 of them were addicted. And so opiates, therefore, are not addictive. Well, that clearly is not the case, but that letter really seemed to have sparked a lot of the opiate crisis. And then we have 1996, when OxyContin was approved by Purdue, and OxyContin was marketed very heavily. There were plush toys, and there were Swiss Army knives, and there was a mug. I think it said OxyContin, the one to start with, and then when you put your hot coffee in it, it would change to the one to stay with, which people really, unfortunately, did stay with it. In about 2004, the coroner started to notice people are dying. People are dying with oxycodone in their system. What's going on? And then finally, in 2007, Purdue pled guilty to kind of misleading physicians, patients, and really heavily marketing this as being a non-addictive alternative to really everything. They were treating back pain and fibromyalgia, and really, it's much easier when someone comes into your office complaining of pain to write a prescription. So, doctors were happy to be able to provide pain relief for patients because, look, it's not addictive, and you're so improving the quality of life of patients, until people started dying. And then Purdue was fined over $600 million, and now we're going to be paying substantially more to provincial health plans to compensate for all the increasing costs. 2012, OxyNeo came out, so this was, great breakthrough. We don't need OxyContin anymore. We're going to have OxyNeo. It's not crushable. It's not injectable. Well, it is if you're motivated enough. And then the problem is the provincial plans weren't covering the cost of OxyNeo, and so physicians had nothing else to use, so started writing prescriptions for things like hydromorphone or things like fentanyl, which really only served to propagate the problem. Finally, in 2017, we have Canadian opioid prescribing guidelines. So Health Canada funded a whole team of clinicians to put together guidelines in terms of how physicians should be prescribing opiates, which is great, and the guidelines look something like that, which I know it's hard to read, but a summary is basically, don't give opiates first line. Let's do non-opioid therapy, non-drug therapy. So massage, physiotherapy, which is great, except nobody has coverage for it, so people can't afford it. So it's great to make it first line, except people can't access it. But if they're on government assistance, any prescription that you write them, any medication will be covered. And so, it's really nice to say avoid opiates if they have a substance use disorder and stabilize their psychiatric problems. I can tell you, trying to get one of my patients in to see a psychiatrist is like pulling teeth. The waiting lists are over a year, so what do you do with someone in the meantime? They set new maximums in terms of what your prescribing should be, which is great, except the horse had kind of already left the barn. So you have patients on massive doses of opiates, and now physicians are afraid to write prescriptions for it. And so what do? They stop writing prescriptions. I can't write you any more opiates. Well, what happens to these people? We already talked about how bad the withdrawal is. Where are they going to go? They're going to have to find other sources. And so, yes, these guidelines are important, but there's a whole host of people who were already on these medications. And we already said, a lot of the, like OxyNeo was not covered, and so physicians went to other things. And we'll talk about fentanyl. So fentanyl was discovered in 1960 by Dr. Janssen. He sold it to Johnson & Johnson. And here we go with the same story again. This is non-addictive. This is a great medication. You should use it really for everything. Initially, because it's such a potent opiate, it was meant for cancer patients. It was meant for significant pain, not someone who comes in who has a sore back. And when the patent expired in 1981, people went crazy with fentanyl. They made fentanyl sprays, fentanyl lollipops, right? So that people could titrate their dose. And then what happens? Illicit fentanyl makes it to Canada. So we're getting fentanyl powder. We talked about how people can abuse the patches. Well, now we're getting non-prescription, non-regulated fentanyl powder coming to Canada, much of it from China, and all of a sudden the overdose and death rates from fentanyl have skyrocketed. And basically we're in crisis now. People are putting fentanyl really in everything. And the problem with fentanyl, so this is Paracelsus, who was a medical professional, he was deemed the father of toxicology, and I love this statement. So poison isn't everything, no thing is without poison, the dosage makes it either a poison or a remedy, which is great. The problem is the lethal dose of fentanyl can be 1 or 2 milligrams. So if you look, that's a standard US penny. If you're looking at how small the amount of fentanyl is, your margin of error for overdose is teeny, right? And so we look at lethal opiate doses, and I like this chart because it gives a real visual in terms of what we're dealing with. So we're looking at morphine, size of a pea could be a lethal dose. We're talking about heroin, we move down to a sunflower seed. Fentanyl, we're talking about a sesame seed. Sufentanil, a grain of sand. And carfentanil, half a grain of salt. Doesn't take very much to kill someone. And that's why when we're talking about things like first responders, carfentanil can be aerosolized. So if you're trying to save someone who has opiates around them, has been using them, and you inhale a half a grain of salt, you potentially could overdose yourself. And so really, the safety risk is huge. Carfentanil was never supposed to be used in humans. It was used as an elephant tranquilizer, and the carfentanil analogs from China were not restricted at all until 2017. And if you look at the potency, 5,000 times the potency of morphine, 100 times the potency of fentanyl. So that penny with fentanyl we looked at, I mean, you can barely see that white spot there. And it's got a long half-life, so it can last for a while. And we're seeing now the potency is so significant that people who go unconscious from opiate overdose get hit with a naloxone kit, need to be hit with another naloxone. I've had people where they've had to be hit 5 or 6 times with naloxone just to be able to get them back in time to be able to get them to the hospital. So we really are in crisis mode, and it's everywhere. It really is everywhere. So I've seen marijuana laced with fentanyl, cocaine certainly laced with fentanyl. They're saying 60 to 70% of the street drugs now are laced with fentanyl. Yep. MDMA tablets. So these are the techs that we talked about, the Percocet that we talked about. So one of these is Percocet, one of these is pressed fentanyl powder. Yep, that's the difference. And if you want to pick out the fake, I wouldn't have been able to pick out the fake. Fortunately, we have the internet and I was able to get that information, but it really, really is everywhere. Xanax. I actually did have a patient who overdosed. Fortunately, we were able to get him back. But if you look at the difference between the real and the fake Xanax, I mean, that's fentanyl powder. People buy the powder, and then they basically buy pill presses and make tablets and then sell them. And you're thinking, well, why are you doing that? You're killing off your customer base, right? So it's really all a matter of money. I was at a conference in Kelowna and I heard this amazing sergeant speak, and he was talking, so he was from the Victoria Police Department, Sergeant King. And so he did a lot of work in terms of drug enforcement and followed a lot of people who had overdosed and was reading their texts and trying to see, you know, are people trying to buy fentanyl or are people trying to avoid fentanyl? And it's really 50-50. Some people say, you know, I want the purple stuff, or I want the other nickname for it is kills. I don't know that I'd be asking necessarily for a drug that, you know, has kills in the title, but if you look at the math, if you spend $2,500 on an ounce of heroin, you can make $11,200. If you spend $4,000 on an ounce of fentanyl, you can turn that around to over $500,000. So it's the cost of doing business. If you lose a few of your customers, you're still well making up for it. And if we look at what's happening across Canada, I mean, we talked about the fact that drug overdose is the number one killer at this point. Over 4,500 people across Canada last year. It's one life lost every 2 hours, mostly from fentanyl analogs. And if we look at this year, we're on par to hit the same numbers just in the first 3 months of this year. And this is despite widespread naloxone kits to try to decrease overdose, despite the Good Samaritan Overdose Act, despite improved access to treatment. And again, if you look at the numbers, 82% involve fentanyl analogs, and a lot of people who are buying street opiates have no clue what it is that they're using. So if people are dying when they're using opiates, why do they keep using opiates? And I like this picture because it talks a lot about drug addiction, about substance use disorder, and the pictorial, to me, speaks volumes in terms of this being a brain disease. This is not people making bad decisions in their lives, although that may be part of the disease. And the word that I like from here, somewhere in there, says enslaved. People do become slaves to the disease. So they start taking a drug, they like it, their brain chemistry starts to change, they want it, their brain chemistry starts to change more, they need it. This is not people just not knowing how to make a good decision. Lots of things underlying why people self-medicate. They self-medicate to deal with physical pain. They self-medicate to deal with emotional pain. Early childhood trauma is a huge factor in terms of any kind of substance use disorder. Genetics, we can't forget genetics. So if you have a first-degree relative that suffers from an addiction, you have a 40 to 60% chance more of developing an addiction than someone who doesn't. Your childhood experiences, all of these affect how much at risk you are of developing substance use disorder. And someone else showed pictures of stereotypes. I'm gonna show that as well. You picture someone who's uneducated, someone who's maybe poor, someone who's homeless, dirty, bruised all over, really doesn't care. But anyone can have a substance use disorder, literally anyone. 1 out of 10 people have symptoms of a substance use disorder, and I promise you the other 9 know someone who does. And if we look at what are the hallmarks of substance use disorder, so the DSM criteria talks about consequences. They talk about physical symptoms. So do you develop tolerance? Do you need more and more of the drug to feel the same effect? Do you have withdrawal symptoms? You can have tolerance and withdrawal, which are physical symptoms, without having a substance dependence. So someone who's on pain legitimately for opiates for a chronic period of time, that are taking their medications and then may need more to make it work or may feel sick if they don't have it, that does not mean that they have a substance use disorder. That just means that they're having physical symptoms. The hallmark of the substance use disorder diagnosis is looking at the compulsion to use, despite the fact that maybe they're losing their job, they're losing their family, they're not able to go to school, they have bad consequences, they're making bad decisions, so they're going to keep driving even though they may have just used and they're impaired. They can't cut down how much they're using more than they want to be using. They're spending a lot of time in terms of trying to obtain the drug that they want. They're having constant cravings, and again, we talked about how important the cravings are in terms of even just affecting your ability to function. So we talked about opiate use disorder being an epidemic, and we talked about doctors trying to cut down on prescribing opiates because they're also under the watchful eye of their colleges, and we have these prescribing guidelines that say you really shouldn't be giving up that much opiate, especially for inappropriate diagnosis. So we're looking at different treatment options, non-pharmacological options. So there are detoxes that are available. It's basically a dry bed. You go somewhere, you're in a safe environment, you don't have access. The problem is you can pick up and leave whenever you like. And this is what most people feel about detox. They don't want to be there. Right? They're starting to feel uncomfortable, they're getting physical withdrawal, especially if you're in a non-medical detox where they're not treating your withdrawal symptoms. They just don't want to hang around. And even if they do hang around for the 5 days or so that they're allowed there, what happens when they go back home into the environment where they were using? And the same stresses are there, and the same triggers are there, and they're actually at more risk when they get out of detox than when they went in, because before they went in, they had some tolerance. They were using opiates all the time. All of a sudden they go to detox, they don't have access to their opiates, their opiate tolerance goes down, and then they come out and think they can use the exact same amount that they used before. So your risk of overdose after having a period of time without opiates, whether it's jail, hospitalization, detox, is substantial. And we see a lot of people overdosing because they don't understand the concept of tolerance being a fluid thing and changing in terms of what they're used to taking. Inpatient residential care is great. Longer-term treatment, counseling, looking at all of the triggers and all of the risk factors. The problem again with opiates is you feel so physically unwell for so long that relapse is significant. Thanks. And then there's long-term outpatient treatments. So 12-step programs, counseling, all of that works great. But really, in terms of kind of gold standard, With opiate, we're looking at medical treatments, and we're looking at various different options. So I'll mention naltrexone. It's an opiate blocker. So it's kind of like someone who's an alcoholic taking antabuse, so it kind of dissuades them from taking it because they get sick. With naltrexone, if you have it in your system, the opiates just won't work. They're going to block the receptor. The problem is, if you don't take the naltrexone, it won't work. And if you are suffering from opiate use disorder and you decide, you know what, I'm not into treatment right now, you'll just stop taking it. Methadone is a very contentious issue, and I know, a lot of people last year were asking me about, well, what do I do with patients on methadone? So I do prescribe methadone. I have a big opiate agonist practice. Methadone is an opiate. It's a very potent opiate. It works on the opiate receptor. It's long-acting, so it's got a half-life of about 24 hours. It's a liquid that's mixed in with orange juice. The problem is that most people don't want methadone clinics in their neighborhood. They don't really understand them. All they see is, okay, it's going to bring crime into the neighborhood. But we know that people who are treated for opiate use disorder with medication do better. We know that it cuts medical costs. We know that it cuts legal costs because people get into less trouble. People do improve their functionality. They are able to work. The question is, can they work in safety-sensitive arenas? And the answer is not a simple answer. Methadone does have impairing effects, especially in high doses. There is a bit of a peak 3 or 4 hours after you take your dose, and so we have to be cautious about that, especially if they're taking it with other medications. We do have another alternative now, which is buprenorphine in combination with naloxone, which is called Suboxone. Suboxone is prescribed for the treatment of opiate use disorder. Sometimes we use it off-label for pain, but primarily for opiate use disorder. It is felt to be less impairing than methadone because it's what we call a partial agonist-antagonist. So it sticks to the opiate receptor really, really, really well and blocks it from other opiates. And it does act on the receptor, but not quite as much as methadone. It works great in terms of reducing withdrawal, in terms of reducing cravings. You don't see as much overdose with it, so it doesn't cause as much of that respiratory depression that we talked about. People don't get that feeling of fogginess. They don't feel like they're in a cloud. But what you need to be concerned about is that their dose is stable. So we usually will tell people, make sure that their dose is stable for 3 to 6 months. There is a little bit of impairment initially when someone is starting on it, though it is less than with methadone. And it does depend on the timing. So there is a peak when you take your Suboxone about 3 to 6 hours after you take it. And I'll wrap up quick because Connor's looking at me. In terms of drug testing, so I see lots of drug tests, and I talk to lots of people about results of drug tests. And the one thing that I'm going to hammer home is if you're going to order a test, make sure you know what you're ordering, and make sure you have a plan for what you're going to do with the result, and make sure you know what you're looking for. So this says, boss, can you pass a urine test? Sure. Distance or accuracy? I can't tell you the number of times we get, someone ordering, tests for marijuana every 2 days, and they can't figure out why it's staying positive. Well, marijuana stays in the urine for a long period of time, so maybe we need to rethink that schedule. So you really want to know why you're ordering what you're ordering. And we test for lots of different substances: cocaine, marijuana, amphetamine, methamphetamine, MDMA, and MDA. We test for PCP because it's on the DOT panel. I haven't ever had never had a positive PCP. And we test for opiates. So DOT tends to be a little bit behind in terms of the testing. So the specific opiates that we were testing for forever were codeine, morphine. 6-AM is a metabolite of heroin. We don't catch it very often because it does not stay long in the urine. Heroin is broken down to morphine, so generally we'll see morphine, but if we see 6-AM, then we know where it's come from. As of January 2018, fortunately, DOT decided it was time to start testing for hydrocodone, hydromorphone, oxycodone, and oxymorphone. So this was 2018, but if you remember my OxyContin slide, OxyContin's been around since 1996. So a little bit slow in terms of the testing, but at least we're getting there, and then hopefully fentanyl is on the radar. So test that's morphine positive can be from prescription morphine, can be from codeine. So if somebody is taking either over-the-counter codeine or prescription codeine, codeine breaks down to morphine in the body, so we can either see codeine or codeine and morphine. Heroin, we said, breaks down to morphine, so if we see 6-AM, we know where it's coming from. If we see morphine, we don't exactly know where the source is. And I put up the bagels because people ask all the time, can poppy seeds really cause a morphine positive? And the answer is yes. So every time I speak to someone and there's a morphine positive, the bagel is in their mouth before I even know what to ask about. But you actually can get morphine in low concentrations from poppy seeds. The synthetic opiates are not going to test positive for morphine. So for many, many years, people who were using all these medications were getting away with drug tests where they were testing negative. And then all of a sudden, January 2018 hits, and they're thinking, okay, why do you know that I'm abusing Percocet now? You haven't known for the last 10 years. So we're picking up a lot more positives now, some prescription, some not prescription. There are certain synthetic opiates that will not show up with those 4 panels, methadone being one, Suboxone being another, and fentanyl being another. You have to test for those specific medications. I won't go through the slide, but suffice it to say, the metabolic pathways of opiates can be a little bit complicated. So somebody may be taking morphine and end up having small amounts of hydromorphone in their system. So when we're doing reviews, we take all of that into account. And when we do a review, we make sure we're speaking to the right person. We let them know that whatever we talk about may be reported to the company because there may be safety issues. We tell them what's in the test result. And then if it's positive for an opiate, we ask about prescription or over-the-counter use. As we talked about 6-AM with heroin, there's no get-out-of-jail-free card with that one. There's no explanation for why you have 6-AM in your system other than relatively recent heroin use within about 12 hours of the test. If we look at hydrocodone, hydromorphone, oxycodone, and oxymorphone, you need prescriptions, and the onus is on the donor to provide. Codeine and morphine is where it gets a little bit tricky. So there's not just a positive and negative. If you have low levels under 2,000, I won't ever hear about that test result. It'll be reported as negative. If it's over 15,000, that's a positive result unless I have some kind of medical evidence that the donor has provided me with, that they have a prescription, that they're under medical supervision. And then there's that gray area that I really, really find difficult sometimes to navigate. So between 2 and 15,000, there's something there. I know that something tested positive, but if the donor's not admitting to anything and if they're not saying that they're on a prescription, it's up to me to prove that they actually have an issue. And what happens is we trigger a medical and we have them see either an MRO or another medical professional to see, are there any signs of opiate use here? Is there anything I should be worried about? Does he look like he's in opiate withdrawal? Are there track marks there? And then if somebody says, yeah, I used something, that's a positive result. If they don't have a prescription and they're testing positive for morphine and codeine over 15,000 or for any of the synthetic opiates, or if they have that heroin metabolite, it's positive. But if they have a valid prescription, it's a negative result. Again, we put a safety notation on it just to make sure that you guys are aware and you know what to look for. If they're in that gray area and they come back with a note from a physician saying, yeah, we don't find any evidence of any unauthorized use, we don't find any evidence of any of opiate abuse at all, then it is a negative result. And then I put a question mark beside spousal codeine use, because sometimes we really don't know what to do with codeine. Because it's available over the counter in Canada, and because everybody has a bottle of Tylenol 3 in their medicine cabinet, you know, depending on what the levels of codeine are, depending on what the stories are, depending on what the policy of the company is, we may or may not say, okay, yeah, maybe you took your wife's Tylenol 3, but we're going to put a notation on the result letter. We may call it negative, but we're going to explain why and make sure that I explain to them that it is a controlled substance and they really should not be using their spouse's medication. And again, we do add the safety concern to the letter. So, as a quick overview, opiates can be prescribed, they can be illicit, you can buy them over the counter. Just because it's prescribed does not mean that it's safe. The other thing that's important is the prescribing physician, much of the time, does not know what this person does at work. They don't know what their safety-sensitive duties are. And so when you're seeing someone who has a prescription, you cannot assume that the physician who wrote the prescription understands all of the potential ramifications and the potential impairment. And we know that opiate use can affect work performance. So it can affect people's cognitive impairment, it can affect how fast people get back to work after injury, and And so we have to really understand exactly what we're dealing with when someone is getting these prescription medications. Again, a verified negative result does not necessarily mean that they're fit to come to work, and that's why we will make a notation on the result letter. It's important that you have a prescription drug policy in place. So again, if you're finding the information, you want to have a plan for what to do when you get that information. And you also want to understand your responsibilities in someone who has an opiate use disorder, which is a disability. And as an employer, you want to understand exactly, what your rights and responsibilities are. So again, the goal is safety of the employee, safety of the public, safety of the coworkers, and making sure that you have a robust testing system and drug policy in place. Thank you very much. I will take questions.